This
Well,
conference will now be recorded.
I guess we're official if we're recording.
We are official.
Okay.
Here we go. We're good.
Here we are. Now, do you see the sidebar in your screen that has all of the chat and everything on it that is mirroring my screen, or just the slides?
No, I have the sidebar, so I can see the chat as well.
Okay. Is it my slide bar or your slide bar?
It says I'm now viewing Lisa Maurice's screen, so I don't know.
Okay, do you see my mouse
I do.
running over the chat section?
I do.
Okay, so you can see that, because I'm gonna, boy, you know what I'm gonna do is minimize that like that. Now can you see it?
It must be mine that I'm looking at.
Okay, so I minimized mine, and I'm probably gonna pull this up on another screen so I can see the chat without, well, if other people can't see this and they can minimize their GoToMeeting control panel is what it's called, then I'd rather have it there where I'm looking at everything, but I don't want it to block off the slide content. Does that make sense?
Yeah.
How about you, Ron and Erica? Are you seeing the GoToMeeting control panel? Can you minimize it on yours if you want to see the slide content?
I can.
Okay, good.
Yeah, I can see it.
Okay. Awesome. Well, then we will, now let's make sure I can hear everybody. Can you hear me okay?
Yes.
I can hear you. You sound great.
Yes, Ron, I hear you quite well. Thank you.
Okay, I think I can hear all of you. So if somebody suggests in chat or something like that during the course of this that they're having a hard time hearing, a couple of the things that we can do is I will switch to a headset, which makes me clearer and also cuts out the background noise from the room. That way, when the dog barks, it's not as much of an interruption. And another thing that can be done is to, if you're on a hard line, to go off of a speaker and onto the handset. But you probably already have experience for what works best for you in your environment. So there we go, putting in my headphones. Ron, are you comfortable with me advancing the slides for you?
Yeah, I'm fine with that. Thank you.
Okay. If I get out of line somehow, you just let me know.
Okay.
This
excited.
conference will now be recorded.
I'm excited to have the opportunity to share this webinar with you from Consumers Advancing Patient Safety, Healthcare Equity, and You. As people are joining us, we will go over a couple of things. This is the first in a series of webinars that we hope to put together that will feature individuals who are working with CAPS. And the topics have actually been chosen by the CAPS team, including our board of directors and our consumer advisory panel. Just so we can hear everybody as they're presenting. If you're not presenting, if you could please mute your line. If you have one of those mute situations where you have music that plays while you're muted, please don't put us on hold and let us listen to your hold music. We don't have a platform that will isolate you, so I can't mute you myself, and so I'll rely on you to handle that. Please type in your name and where you're from in the chat box. We'd love to hear from you that way. And as we go through the presentation, feel free to type in your questions, both for our presenters and just in general, and we'll get to those as soon as we can. Our presenters today are Erica Gollett-Steed, who is a patient advocate and also the former manager of Patient and Family Center Care at the Georgia Healthcare System. Erica has a long history in patient and family advocacy. And we have Ron Wyatt, who is a physician and the Chief Quality Officer at Cook County Health, which is one of the largest public health systems in the United States, and is also the former quality officer for the Joint Commission. So we're very honored to have Ron with us today. Our agenda is that first Erica will be sharing her healthcare equity story. Then Dr. Wyatt will discuss health equity, disparity, and multiple determinants. And as we go through this, if you could think about what you personally can do as either a clinician or as a patient or caregiver to impact and improve equitable outcomes in your situation. So without further ado, we'll get on and turn it over to Erica to share her story.
Thank you so very much, Lisa. So once again, my name's Erica Gollett-Steed, and I'll be before you no more than 10 minutes. I could really write a book about the experience that both myself and my son, Ellison Steed, have experienced over the last 12 years, but I'll just keep it brief. So in a nutshell, I'll just start with the photo that you currently see before you. Me and my husband, at the time, we were both dual family veterans, so we had already finished our 4 years in the military. We served our country in both Germany as well as in Texas. Both two well-educated individuals, no student loans, thanks to the U.S. Army. My husband is an engineer by background. As for me, I think I just love school. First, I started off and I got my associates in accounting. Then I said, oh, okay, I guess I'll go further. And then I got my bachelor's in marketing, and then I said, okay, now I want to get a BS in computer science, and then I went on to get my master's in management. So both of us well educated, like I said, prior military, very goal oriented. We had our careers ahead of us. We did, we checked off all the boxes. We had been married 7 years. We were homeowners. We had traveled a lot, between Germany and Hawaii and Japan, Spain, France, the Caribbean islands. We had done a lot of traveling. And in those 7 years, we had finally decided, okay, I think now it's time for us to have children. So we decided that it was time to have our first child, and it was actually planned. It wasn't a mistake. We decided that it was time for us to have our first child. Next slide, please. So what ended up happening, we were blessed with our first baby boy, and his name is Ellison Steed. And I would like to say that I wish that my pregnancy was pleasant. However, it wasn't the best pregnancy. I'll start off by saying, the pregnancy was pretty rough. I recall talking to my physician about the fact that it was I was seeing a lot of spots, so like the black spots in the air and the floaters, so to speak, in the air. And I thought I was concerned about those things. And I mean, I just felt like I just really wasn't listened to on the front end. It's like, what do you mean by floaters? What exactly are you speaking of exactly? Then fast forward to me actually having delivered my son. I ended up going home. I would say that post-discharge phone calls was essential. I think that's what saved my life. They called with a post-discharge phone call just to check on me and to check on Ellison. And in the couple of questions that the nurse asked me about, I told her I was feeling dizzy and my vision wasn't quite where I would expect it to be, because normally I have 20/20 vision, but I'm sitting in my living room and I'm looking at a clock that I normally look at, and I really can't tell what time it says. So she proceeded to ask additional questions, and she said, I think you probably need to come into the hospital. Do you have a visit coming up soon? I said, actually, Ellison is coming in to get his circumcision checked on today, so I'll swing by then. During Ellison's visit to just go see the doctor, they decided to check my blood pressure, and at the time, my blood pressure reading was 179/102. They immediately rushed me to the emergency room, and I was admitted into the hospital. Fast forward a little bit more, they immediately say, okay, this is a rare case, but you have preeclampsia. So usually you have preeclampsia like while you're pregnant, not after you've actually given birth to your child. So I was having hypertension was just through the roof, and they ended up admitting me into the hospital. So I wanted to first start off by saying I felt like I wasn't listened to on the front end when I was talking about many of the floaters that took place. So now that I'm in the hospital, I ended up having to take mercury. And that was going to help me to get my blood pressures under control. This is 2 days into my stay, and the nurse happened to walk into the room and realized that I was breastfeeding my son. And she said, wait a minute, you're breastfeeding? And I said, why? Is there a problem? And I mean, she immediately panicked and said, oh my gosh, I'm not sure if you should be breastfeeding with the medications that you're currently on. I was kind of shocked and thrown aback by why didn't anybody tell me this on the front end? And I will never forget this. She says, I'm just not used to seeing Black young mothers breastfeed. So the fact that no one asked me that question to make sure that I was on proper medication, or what was going to be the side effects to both me and my son, I was completely shocked that the assumption was made just because I'm a young African-American woman that it wasn't a possibility that I would be a mother that breastfeeds their child. I immediately discontinued breastfeeding Ellison at that time and continued on with my treatment. Before I was actually discharged, it was time to, and I forgot I skipped this part, with all of getting Ellison's paperwork as far as, getting the birth certificate signed, I then ran into another issue where me and my husband did not share the same last name at the time. And this is only because my husband at the time, his last name had just been switched to Steed. For the 7 years of our marriage, both of our names was Reed, and Reed is his mother's last name. But when we found out that we were expecting our first child, he expeditiously went ahead and got his name changed because he says, okay, moving forward, I want to make sure that my children bears my father's last name. So my last name at the time was still Reed. We had just paid over $2,000 for my husband's last name to be switched to Steed, and the assumption was made again that he was my boyfriend and not my husband, and I was having problems with getting him his signature on the birth certificate, and they were saying that my son's last name needed to be Reed like mine and not Steve like my husband. So once again, another assumption that just because our last names was different, that he had to be my boyfriend and not my husband. Continuing to fast forward in the story, at about 18 months of age, Ellison just really wasn't developing the way we wanted him to develop. And I was just asking a lot of questions about, I'm not really sure about what's going on here. Took him to the doctor to be evaluated. And I'll never forget the doctor handing me a white envelope. She never shared the prognosis. She said, I just really need you to, and I still choke up about this. She said, I'm just going to give you this white envelope and you need to take it to this particular specialist. Well, of course, I'm sure you all know what happened. I didn't wait. I got into my car. Well, actually, I walked back across the street where I was at the same hospital that I worked at. And I opened up the envelope and it talked about there being a delay and the possibility of autism. Now, why was I so choked up about it? Because I had already, did my Google. I was my own physician. I had already started Googling some of his symptoms, and I felt like autism was probably what was going on. But for her not to share that information with me and to put it in the envelope for somebody else to share with me, I just found that to be highly disrespectful. When I did go to the appointment with the physician, he had informed me that, he was, really managing the other physician up and speaking to the fact that, yes, she's recommending your son to be in the Babies Can't Wait program. It's an excellent program for children who are 3 and under, because we can't get your son because, we're not going to have him in the having a speech and occupational therapy because that's really expensive, and that's something that we can't cover here at the hospital. Medicaid isn't covered here at the hospital. So once again, another assumption had been made that I had to be a Medicaid, that was my insurance type, that it was Medicaid, and not that I actually at the time had Blue Cross and Blue Shield. So I had to fight for that because that question wasn't asked of me about what my son's insurance was. So we ended up doing the Babies Can't Wait program, as well as we ended up starting speech therapy in the hospital. Going a step further with assumptions, I feel like so many things went wrong just because assumptions were made. And I just really think if I had to give you any takeaways here today, I think we have to be aware of our personal assumptions and what we may think of a group or of, I'm even guilty of it. Growing up, I was always told, like the Latinos carry machetes. So it's things like that you think it's, all in, just from TV or jokes, but it can actually manifest in the way in which you treat people and treat individuals. So as a result of all the things that have happened to me, I have become a huge patient advocate for individuals who are on the special needs spectrum. I am definitely a mama bear when it comes to my son Ellison, as well as my daughter Iliam. And I'll also say that and this is it's a shame that I have to do this, but a really close friend of mine, her name is Christine Abbott, she shared with me one day, she said, hey, Erica, I know you're paying all of these copays for your son's visits. Have you ever heard of a program called Katie Beckett? And, okay, what's that? And she went on to give me the information. Well, it's a form of Medicaid, but it's not based off of your wages. And your son has, what's considered a chronic condition. It's not like autism is going to go away just as a result of you giving him a shot or whatnot. So I really think you should look into this. I looked into it. My son has been approved, but I catch myself often when I go take him to doctor offices or he's meeting somebody for the first time, I'm always saying, he has Katie Beckett. It's a form of Medicaid, because I don't want people to look down on my son as well as my family and assuming that just because he has Medicaid that we are depending upon the government to provide assistance for us, when in fact it's really nice to have that cushion so I'm not spending over $120, $150 a week just in copays. So the photo that you see before you right here is just various photos of Ellison. Like I said, me and my husband, we were avid travelers before we had children, and I'm so thankful that we continue to travel now, even with Ellison and with him having sensitivity to noises as well as lights. He loves still going to various sports endeavors, as well as he loves doing traveling. So Ellison has had a lot of travel in his books, and we're really excited about that. Next slide, please.
I think that's it.
Okay. Well, the slide that I was gonna, okay. So the one slide, it must.
I'm going to go back.
I was just going to share. This is my sweet Ellison, and he's just like any other kid, except he's autistic. And he's a basketball star. He's on the swim team. He loves taking selfies. He plays the trumpet in the band, and he's a social butterfly. So I just want to just share that my story, and I know my story is one of millions of stories about us really just needing to be aware of our personal assumptions and not taking shortcuts, and just really reflecting on how we can be change agents to make sure that everybody is treated equally and fairly with their health care. And I will stop there. Thank you so very much.
Thank you so much, Erica, for sharing your story. I just, it breaks my heart that you've gone through what you've gone through, but you have persevered, and Ellison is doing so well. Didn't he just recently march in the school band or something along those lines that you shared?
Yes, he was actually the conductor, so we're very pleased. He does really well with multiple instruments, and just to think that this kid was nonverbal for about 7 years, wasn't potty trained for the first 6 years, and now he's quite the popular kid at his school.
That is amazing, and really you have done a great job, and appreciate your advocacy and taking the time to share your story today with us. And now we're going to turn the time over to Dr. Ron Wyatt. Dr. Wyatt, you have a wonderful presentation to go through.
All right. Thank you. First, thank you, Erica, for sharing your story and Ellison's story with us. Thank you, Lisa, for all your hard work behind the scenes with logistics and getting all of this set up. Likewise to the CAPS leadership. And thank you to all of the participants online for taking time out of your day to really start to think through these topics. And I'll say up front that we're still pursuing solutions to some of the things we'll talk about. And as I go through my presentation, I hope you'll reflect on some of the things that Erica shared and how they align with some of the topics that I'll try to go through. So next slide, please. So we'll just kind of start with this from Martin Luther King Jr. This was a quote from here in Chicago in 1963. All the forms of inequality, injustice in health is the most shocking and the most inhumane. Well, next slide, please. What historians will say is that, in fact, Dr. King did not say inhumane. That was in a way watered down. But what he actually said was that it's inhuman. And some of the structural and institutional challenges that Chicago faced in the 1960s, specifically on the South Side, it is sad to say that some of those and many of those same institutional and structural barriers exist even today. Next slide, please. So we'll go through what is equity, what is disparity. We'll discuss the relationship between equity and patient safety, talk about what I prefer to call the multiple determinants of health, and then just recommend for your thoughts what an equity strategy may look like or what it might consist of. So next slide. So I think for some of this, some of you will know, some will be new to you, but I think it's always important to go back and look at our history and then to look forward to where we are. So I'll start by talking about W.B. Du Bois' work that was done around 1899. And this was a scientific work that Dr. Du Bois entitled The Philadelphia Negro. And he uses a term in there that has always resonated with me as he talked about the differences he saw in the populations in Philadelphia. And what he called it was a peculiar indifference to the populations that he studied. Next. Then we move forward a bit and we go to Booker T. Washington, who was at Tuskegee Institute, and that should resonate with many of you, where the first Negro Health Improvement Week was started that subsequently led to the U.S. Public Health Office of Negro Health Works. Next slide. And then we fast forward to the Heckler Report. That was a monumental report by Secretary Heckler that really started to establish the details, the facts, and the data around Black and minority health, and specifically looking at the excess deaths in non-white populations. Next slide. And then the Harvard practice study, again, expanded on that work and started to document the variation and substandard care in non-white populations. Next slide. And we go through to the lifelong work of Senator Kennedy and the establishment of scientific research to begin to look at the reasons behind problems with disparities in racial and ethnic groups. Next slide. So then definitions are really important, and I'll give you a few that I prefer. One is health equity. This comes from Margaret Whitehead and the World Health Organization. Ideally, everyone should have a fair opportunity to attain their full health potential, and then no one should be disadvantaged from achieving this potential if it can be avoided. So my kind of everyday speak translation is, if I want to be healthy as a person, I say to you, please don't block the door. Let me achieve the level of health that I want to achieve. I spend more time now talking about what is health inequity. And here are the differences in the outcomes. These are systemic, they're systematic, they are avoidable, they're preventable. And back to that first slide, they are in fact unjust. So next slide. When we think about what is disparity, then this is a particular type of health difference. So we go back and remember what W.B. Du Bois told us about this peculiar indifference. So there's a health difference that we now know is linked to socioeconomic and or environmental disadvantage. Next slide. And that there's a limit, continued improvement in population health that results in unnecessary health costs. So that's underuse, overuse, or misuse of resources that impacts healthcare costs. Next slide. Back one. So if we began to think through this a bit more, then there are barriers to achieving the highest level of health that a person wants to. You know, I call these the fences of inequity, and you've seen many variations of this slide. So what you'll see here is the difference between equality, equity, and then when you see all of these fences removed, some will say then this achieves a level of health liberation, which is, I think, in my mind, beyond health equity. It is health liberation, so that then as that little person that you see there can achieve his or her full potential, that they can grow, they can be as tall and as strong as anyone else once these barriers are removed. So next slide. And what we have to begin to recognize that health inequities are harm. And then when we begin to stratify, segment the data, and look at the different populations that are most impacted by inequity, they are LGBTQ, they are non-white populations, they are non-English speaking populations, they are people who have some type of disability, whether it's physical or cognitive. We bring in ageism into this as well. So there are many ways that inequities are expressed in harm to the populations that we engage with. Next slide. So if we look a bit more at the disparities, I am from Alabama, and I'm from a particular place in Alabama. It's called the Black Belt. And inside the Black Belt, there's a county called Perry County, which is where I grew up. And there is an effort underway in Perry County, Alabama, that's called Sowing Seeds of Hope. That's in Marion, Alabama, where I grew up. I bring this out because Alabama has higher rates, death rates from cervical cancer of any state in this country. In Alabama, the death rate from cervical cancer, when we compare Black women to white women, is 5.2 deaths to 2.7 deaths. Death from cervical cancer should be a never event. And in fact, there was a publication entitled, "It Should Not Happen." So here are these disparities that truly, when we think about cervical cancer, is something that really should not happen. Next slide. So then I'll get into this a bit later, but in terms of disparities, and something that Erica alluded to, is that there are deep-seated beliefs and disbeliefs and misbeliefs and stereotypes and biases that go back as far as when individuals go to medical school. And here's a study from Virginia where medical students believe that black skin was thicker than white skin. That impacts how decisions are made, how clinical decisions are made, and how that clinical encounter, and we'll talk about later, what happens during that clinical encounter when those decisions are being made. Next slide. So when we think through disparities again, we always talk about the access to equitable care as a problem here in the United States. That there are disparities that have been documented and well documented with insurance coverage, and quite frankly, for people like in Erica's story that have adequate insurance coverage. And then we need to start to begin to take a closer look then and target what are those factors involved with creating these disparities that I would again say are preventable. Are there linguistic biases, cultural biases, social and environmental needs that are not being met? When we go back to access, access is more than did I get the third next available appointment. It becomes, were there language barriers? How was I spoken to? Was I respected? Did you show me empathy and compassion when I came in for that visit? So we have to broaden out what we mean by access more than I was able to get that appointment. It's what happens next after I get that appointment that contributes to the persistent disparities that we see in our healthcare system. Next slide. So then when we begin to think through equity and patient safety, I'll make the provocative statement that there is no patient safety if there is not equity. We can take this back to the Institute of Medicine's domains. Equity sits there. It's been called the forgotten aim. And as we begin to think about equity and safety, we have to have these uncomfortable discussions about biases, both implicit and explicit, and what are those structural biases and structural inequities that lead to harm. And then how can we begin to enforce, to monitor, to measure standard approaches that will lead to increased safety for all the people that we care for. We know that we really don't need a lot of additional research on this topic. We know that socioeconomic characteristics of patients as well as workforce even impact what's reported as a safety event, what's acted on if it's recognized as unsafe, and then what outcomes result from those decisions that are made or possibly not made, depending on characteristics around if a person is a minority or from some other group. Next slide. So when we begin to think then through an approach to equity and safety, there has to be, and I would say these, a long list, but these are probably a minimum. An organization, a clinician provider, a system needs to set the tone and the vision. Equity and safety, the profile has to be raised. We need to understand what those systems failures are that are the root causes that lead to persistent inequities in our system. This requires courage. And as we find that courage, the next step is to reward that courage when the workforce demonstrates advocacy for patients who otherwise are impacted by inequities. Then have a strategy. Make sure that the strategy aligns with resources. Said another way, it's not enough to have a strategy. You got to put your money where your mouth is. Set your aims to improve and be bold about it. Use the data to bring us together with the families and the people that we take care of. Be a part of the community. Understand what's important for that community. What does that voice say? How are we partnering with the community? And then to use that to redesign systems and admit, I think, that we have systems that need to be redesigned, and they need to be redesigned as it relates to equity and safety because they're not working. And then persist, persist, persist. Next slide. So if we start to think then about those contributors to inequities and disparities, let's look at the state of the U.S. for a second. So here, each year in the U.S., we know that there's about 1.5 million people that are homeless. 3.5 million or so cannot access health care due to transportation issues. 42 million face hunger. And 12.5% of households are food. So about a year ago, I had a meeting, dinner meeting with a person named Joel Berg, who worked in the FDA under the Obama administration. And he said something that was so enlightening to me here in Chicago. He said that the day of the week that had the highest school attendance was Monday. It was Monday because you had so many kids who were hungry because they didn't get enough food on the weekend here in Chicago. So we talk about place matters, but we talk about also food matters. So next slide. So when we began to start to think about what are these determinants, it's very popular now to talk about what's called the social determinants of health. And I won't read through those, but many of us are now, there's in some cases, there seems to be almost an arm race around the social determinants of health and how we begin to address them. There's no doubt that these social determinants that I call multiple determinants result in these inequities. And for me, another way to think through these multiple determinants is the things, the stuff that are really hurting, harming, and killing people prematurely. Next slide. And this is a layout or a framework that begins to think through the impact of these determinants on health and well-being. So it begins with just a socioeconomic and political context that leads into these determinants that includes socioeconomic position, class, gender, ethnicity, education, occupation, income. These are these structural determinants. Then you lead to intermediate determinants that bring into play circumstances, behaviors, psychosocial factors, all of which then impact inequity in health and well-being. Next slide. So if we think then about what are these multiple determinants, again, not a new definition, this is back to 2002. These are the life-enhancing resources: food supply, housing, economic and social relationships, transportation, education, health and health care, and how these things are distributed across a population that impacts not only the quality of life, but the length of life. Next slide. So when we start to break these multiple determinants down, then what you'll see here is that 50% of the multiple determinants are socioeconomic factors that go back to your zip code. So here in Chicago, if I look out my window, I can see the United Center, which is the near West Loop. It's about 2.5 miles down to the Gold Coast, and then another about 2 blocks from the United Center is where I live. So from the Loop on the Gold Coast in Chicago out to where I live, 18 years of life expectancy are lost in 3 miles. 18 years. Also, what happens in that 3 miles is the income, median income, goes from over $100,000 per year to a little over $20,000 per year. So it traces back to that zip code, physical environment 10%, health behavior is another third, and then healthcare is only 20% that contributes to these multiple determinants of health. Next slide. So these multiple determinants, and we could talk on and on and on about every one of these, but I think we all understand these now. Economic stability. What is the health and healthcare in the community? As an organization, as entities, as advocates, do we truly understand the social and the community context that and how they contribute to these determinants? What is the educational resources in the communities that trust us, that we're here to serve? We need to better understand what those resources are, where the gaps are, and how we can partner with neighborhoods and communities to improve education. And then looking at neighborhoods and the built environment, particularly as it relates to people who are older, people who have disabilities, and what that community looks like. So from where I live, typically I'll walk several days a week, about 3 miles round trip from where I live. And as I walk, across the street, there is a Wendy's, there is another fast food place, there is a second fast food place, there is a pawn shop. I turn a right and go in front of Pete's Fresh Market. I pass a Domino's Pizza and some other fast food shops. The sidewalks are uneven, they're crooked. Now I know where the uneven spots are in that sidewalk, so I can avoid them so I do not fall. Once I get about 2 blocks away and I cross the street, Damon Street, where the United Center sits, the sidewalk smooths out. The covering on the sidewalk is an anti-fall covering. And that's for the people that can afford to go to activities at the United Center. And as I go further east toward downtown Chicago, again, you see that the built environment looks different. Those are the things that we as advocates and providers need to be mindful of, and how we engage with communities so they can be safer. Next slide. And by the way, it snowed here in Chicago today. So when you think about out walking in places where the sidewalks aren't cleared away or taken care of, that's a part of health. That is a part of inequity. So we have to develop these system-wide strategies that goes from the clinical encounter to what are our organizational structures and processes that can get us to better outcomes, and then how we begin to partner in a much more robust way with the communities that we're here to serve. Next slide. So if I pause for a bit about the clinical encounter, I'm an internist, practice over 20 years, mostly in Alabama and St. Louis. So it becomes a critical moment, that clinical encounter. That's when we begin to understand people, the communities, what are those determinants that are impacting their health. We can begin to take an assessment of what are those non-medical factors that we need to think through, and how we can hardwire those into all of the planning that we do as we establish our structures and processes. Next slide. So in that clinical encounter, then there are some things we need to be aware of, and again, back to some of this resonated with me as Erica was speaking. So we know from studies that 2 out of 5 medical students have a bias against people that are obese, what Malcolm Gladwell calls sizeism, and how that impacts clinical decisions in that clinical encounter. As I stated earlier, clinicians may order too few tests or too many tests, depending on symptoms or if there are issues around English speaking, and these impact a person's health and well-being. It increases exponentially the opportunity to make an error if you're ordering too few or too many tests. And then a statement that comes from the Cook County implicit bias training is on the part of medical students: if I keep my biases to myself, does it hurt anyone, right? So the answer is yes, it does. And we've got to find ways to work through unconscious bias, implicit bias, racism, and racial indifference that impacts patient care in that encounter. Next slide. So this is a listing, and I won't go through those, but this is from the study that shows the questions that medical students were asked about their beliefs. And you can see that these are quite shocking when you read through those, again, including the one that says that Black skin is thicker than whites. Next slide. So then this impacts, again, clinical outcomes from Van Ryn, and it talks about the outcomes from hypertension to sleep disorders. When we miss or ignore or are not aware enough of symptoms that can lead to severe cardiac events. Cancer screening, prevention, and treatment, as I talked about with cervical cancer screening in the state of Alabama. But if we go nationwide, just with cervical cancer screening, there are 4,200 women who die every year because of from cervical cancer. And a large part of that goes back to what happens when we make clinical decisions. And then assessment, treatment, and referral of mental health services, and how critical that is for vulnerable populations. Next slide. This is a recent article, and as we all think through artificial intelligence, machine learning, algorithmic approaches to managing populations, this is a recent study that looked at an algorithm to manage healthy populations. What it found was that this algorithm made racial differences between Blacks and whites based on an algorithm that potentially could lead to worse outcomes for the Black patients. So the question was there racial bias built into this algorithm? These researchers say yes, there was, and it has to do with some complicated factors. And in fact, if you get a chance to read it, they use the example of Henrietta Lacks. If you don't know that story, Henrietta Lacks originated the HeLa cells from Hopkins. And what they said is if you apply this algorithm to Henrietta Lacks when she presented to Hopkins in the 50s, she never would have been diagnosed. She would have been sent out from that visit. So we really need to think through everything we touch in terms of technology to make sure that it's not reinforcing these biases that already exist. Next slide. And then it comes to the organizations. We've talked about some of these as families, as patients, as advocates, as organizations. We need to be aware of our impact on a community. We need to make sure that we're looking to see how we can bring people in from the community to work in our organizations. How are we helping people who are disadvantaged in the job market? Are we making sure that when we bring people in, we're not practicing ableism? Do we have a check the box mentality for people who are formerly incarcerated? Are we using minority and female vendors? And I'll say here at Cook County, it's an extremely proud moment for me when the board begins to ask about female local vendors and contractors, and are we complying with our obligations and requirements around minority and female vendors? And then, are we being environmentally responsible? We have to avoid hurting the air, the water, and the soil. When we begin to look at where vulnerable populations live and how that impacts us, the most common story we hear now is about Flint and the water. If you look at St. Louis and some of the places where toxic waste has been stored. If I go back down to Alabama in a place called Triana, where an entire Black community had to be relocated because of toxins that had seeped into the watershed from a local plant. And that area still in some places is not safe to live. What does this do then? And it, again, goes back to something Erica talked about. It impacts trust. And as organizations, we need to have the trust of the community. We need to live and breathe and be a trustworthy partner as we plan our health and healthcare approaches for the communities that we serve. Next slide. So we need to become that community partner. Our strategies, all of our strategies, need to take in consideration these multiple determinants, understand the complexities of the communities that we serve, make sure that our health strategies are not just in a binder on a shelf, but that we revisit those strategies and make sure we're making progress, making sure we didn't make a situation worse. And we began to think through, do we have the old term, a shared mental model between our organization and our community? Next slide. And then practice for leadership. And here I'll pause again because, again, there's been sort of an arms race in organizations to invest in and resource teaching methods and tools. What we need for the patients, the families, the communities is leadership that is fully present, that's fully engaged, that has an actionable dashboard, that understands what that dashboard is saying. Not a leadership that says we got a lot of green, therefore we're doing well, but it's leaderships that start to say, my dashboard shows all this green, there's a little bit of red over here. I need to understand why this green is green and how we can turn that red green, not just to be happy with, well, thank you, didn't bring me any bad news, let's move on. So we need to make sure that leadership is strong, engaged, present, and that we practice humility for the communities we serve, for the families we interact with, for every person that comes into our care, and that we do that from the perspective of a servant leader. Next slide. So as we think through this, then for the group here, some questions to reflect on or run on that I would ask that either now or later you begin to ask yourselves, take them back to your organizations. How do you feel about this? What are your thoughts? What are the possibilities in your organizations for addressing these multiple determinants? Which of these do you believe are the most pressing ones in your communities? And what steps can you take if you're a policymaker to determine where you can best serve the communities and people and families around these multiple determinants of health? Next slide. So this is the IHR framework. This goes back to the Achieving Equity White Paper. And these are the recommendations from that paper: making health equity a strategic priority, developing structures and processes to support the health equity work, deploy specific strategies to address the multiple determinants of health, eliminate institutional racism and other forms of discrimination that exist in many organizations. And again, as I've harped on a bit, how we become true partners and servant leaders for our communities and community organizations. Next slide. So if we set at a minimum, then what are some of the components of an equity strategy that we need to consider? Define what equity is. What is that operational definition, and how do you contextualize it for your locality? Commitment is huge. Make sure that you commit to having equity integrated explicitly in your organizational strategic plan. Leadership has to commit to certain behaviors that will signal the importance of equity. Be able to articulate how equity and inequity um, uh, aligns with new business decisions, where to work, who to work with, whether that's in organizations, your faculties, or public-private partnerships. Be able to speak to how you plan to advance equity competencies on your team. Do you have competency training? Have you begun to have discussions about cultural humility in the organization? Are you partnering around the communities about how the community feels about our approaches to a different culture? Name the processes where equity should have an impact and measure them. And then it's not enough to go through all the strategic planning if you don't operationalize your strategy. So test and learn and track. If you have a failure, what did you learn from it? And how can we improve for the next round? If you have specific projects, I would recommend that equity be a part of every single project that our organizations roll out on the teams. Is there equity competency being progressed or not? If not, then what are those reasons? Why is it not progressing? And then we have to, again, go back to that courage to advance that work and continue to progress in those processes and redesign those processes. So I am at 30 minutes, and I will say thank you so much for your time.
Ron, you are amazing. Thank you so much, Dr. Wyatt, for sharing all of this with us. And I didn't mean to cut you off there. I think that this is probably some of the most important information that we have today in terms of achieving better outcomes across the board in terms of quality and safety. And I really appreciate you taking the time to put this very impactful presentation together for us so that we could learn and answer these questions. And we do have these questions that the lines are open, and we would welcome a discussion at this time to go through this information and give us your thoughts. And I'm going to warn you, I may call some of you out to share what you're thinking. And feel free to chat it in as well. So Eileen Balku, who I'm so excited that you're on this webinar because I don't think I've talked to you in 6 years. But Eileen is on this, has typed in a question. If we could have some concrete examples that you have used in health equity efforts. Dr. Wyatt, do you have some examples of what you may have utilized in your health system?
Yeah, so in our health system here, there's several areas that we're looking at working on. I'll preface that by saying most places are early into this work and begin to understand this work. So what we've begun to do just around what we call social determinants is making sure that the social determinants are then coded accurately. So we'll know how to act on those. We have a robust transportation program. We have a robust partnership with the food bank here in Chicago. And I can't tell you now off the top of my head, but there's been tons of food distributed through that partnership as a result of the work here at Cook County. We have a housing program. We have a jobs program. We're very active about making sure we have adequate interpretive services. So in the Cook County system, the two primary languages that are spoken for inpatients are Polish and Spanish. So we're making sure that we have those things in place so that we can make the right decisions. We're looking at the data to see what patient population is utilizing or overutilizing the emergency room. We're focused there on heart failure patients who come back into the ED. What we found through the data analysis is that many of those patients are Black males between the ages of 48 and 52. Right. What we also found is that they come back to the ED, but they're not readmitted. They're in observation or they're discharged, Many, we find out, have substance abuse disorders. They are homeless, or they cannot afford the medicines that they got prescriptions for on discharge. We're focused on what happens at every area of transitions planning in the system to make sure that we're addressing some of these multiple determinants as best we can. So those are some of the things. We're early into the work, as most places are. And someone asked, but yes, we actively have a social work team that are spread thin, as you can imagine, because here at the Cook County Health System, we provide more uncompensated care than all of the other hospital systems in Chicago combined. So you can imagine how then stretched thin the social workers are trying to address all of the issues around these multiple determinants that we're faced with. We have clinics in schools, school-based clinics, where we address these. We've just rolled out new training on implicit bias and cultural competency, where we're beginning to have discussions about cultural humility. So those are some examples.
Well, that sounds like you're doing a lot of really great work in terms of the community. I had an opportunity to speak with a provider in southern Georgia who was working with school-based clinics in developing telehealth with specialists up in Atlanta. It's a difference in people having to make a 4-hour drive to and from to get the health care on a timely basis that they need, especially with specialists. So I think there's a lot of opportunity for growth in areas like school-based clinics and telehealth and outreach to our communities. One thing that has been interesting to me, Dr. Wyatt, that I would love to hear you address is the line between looking at community and social determinants of health and individuals and looking at what their needs may be. Now, if you look at zip codes in my community, which is obviously markedly different than Chicago in Salt Lake City, but if you look at zip codes, nobody in my zip code needs any help. However, I can tell you that 25% of the individuals at my local junior high school are on free lunches. And we have food insecurity just down the block from me, where neighbors often intervene to provide food assistance to individuals whose pantries are sparse. And I've visited neighbors in the hospital who have not eaten in a few days, parents who have not eaten in a few days because they don't have the money to purchase food in the cafeteria, and made those interventions myself as a concerned neighbor, but the hospital wasn't assessing for that at the time. So how do we balance actually assessing the individuals that present, regardless of where they may be from, and meeting the needs of communities that we identify have greater needs?
Sure. So it's a big question, and I wish I had all the answers. I'll just give you some of my personal perceptions on this. So one, I would say, like in your case, we have to say no data is data. So we can easily say, well, this is not a problem in my community because I don't see it, or the data doesn't say so. So then part of this work is, are you in the community? Are you engaged with the community, as I talked about? If we go with a healthcare system or organization, simple question, as the C-suite leadership, when was the last that the C-suite leadership was in the communities that serve? Does the C-suite know the communities that are served? Is anyone sharing that data with the C-suite or the decision makers or the policy makers in that organization? It's what Kamara Jones calls in her paper, The Gardener's Tale. Who is the gardener in these systems? And how are they using the data? Do they believe the data? Who is in the organization advocating to say, let me show this to you? Let's go and talk to the community, because guess what? The answers and the solutions to many of these challenges are in the community. So what are those challenges in that community? If we're in our four walls every day making the usual decisions that we make about how to provide healthcare that are important, we have to be servants in the community. I'll give you the example of a visit I made down to the North Mississippi Medical Center twice now, and they won a Baldrige Award. First time I visited, they showed how they had become a part of the community there in Tupelo, Mississippi. So when the question was asked, why, and what drove this, here's an organization that, like many of us, have a very, very small revenue margin. What the leadership said was, we lost our community because in our arrogance, we decided that the community was here to serve our needs. And we began to lose our community, and that community started to go to Memphis or as far away as Jackson for care because of the failures in leadership in that system. So they actually went to their community and apologized. And they said, in a way, we lost our way. And what the CMO said to me has always struck, and I've used the term several times. We decided as a leadership team that we would be servant leaders in our community, that we would do things a different way, and that would become who we are. And those that don't want to be a part of that, we can love them from afar, but we have to be a part of our community. And that's, again, a community that is largely vulnerable populations, largely a Black population, largely a Medicare, Medicaid population. And I would say if it can be done there and an organization wins a Baldrige in Tupelo, Mississippi, it can be done almost anywhere. So I think it goes
I love that.
Leadership's commitment. Have they identified if there is no data about equity and disparity? Leadership should commit to saying, I want to see the data. I need someone to explain this to me. We need to make sure we're spending resources strategically in the right way to address the needs of the people that trust us to serve them.
So we need to see the data, and we need to get out in our communities. And I think that those are excellent points. I just want to ask Erica quickly to come on and share with us what you think an individual can do to avoid the situations like you have found yourself in, and many others, including other people I've talked to that are on the line today, have found themselves in terms of implicit bias and inequity. Erica, are you on mute?
Oh, I'm sorry, I was. I lost my train of thought. I'm sorry. Say the first part again.
What do you think an individual can do to avoid situations like you found yourself in?
Wow. I mean, first of all, I would just have to say, just by not making assumptions, not thinking that it's the same protocol across the board for everyone, and to just really ask questions. For me, I wish I had said, hey, I'm breastfeeding, so what about this medication that I'm taking? I wish I would have had, asked more questions about how does it look differently with this insurance carrier versus that insurance carrier. So I think for me, I was very naive and novice to healthcare. Even though I worked in a healthcare center, I just wasn't on the clinical side of the board. I just think that the same way we ask questions about the new iPhone, or the same way we ask questions of the teachers at our children's schools about, their report cards, I think we have to be basically the CEOs of our temples. And I failed myself, so I'm just not going to put this all on the health system. I failed myself, and I just think more education needs to be provided to us as patients to be CEOs of our temples, and to really make sure that we are informed and that we are doing what's needed.
Boy, I really like that, Erica. Be the CEO of your temple. We are at the top of the hour, and I think we probably could just visit about this for a long time. But I want to thank everybody who joined us today and let you know what's next. We will post an executive summary of this webinar in a PDF in our resources section of www.patientsafety.org. That's our website. And we have recorded this webinar, so technology willing, we will post a recording that will be available until our next webinar for people. And so if you have people in your network that you are wanting to say, hey, you should have been there, this was good stuff, please refer them to our website to have the opportunity to learn. We are going to have our next CAPS Perspectives website or webinar will be on December 12th at noon Central Time, honoring faith and holiday traditions in healthcare settings, which is also an equity-based webinar. And we will send out links to that as the time gets closer. We have a number of exciting topics that we have talked about with our consumer advisory panel, and we're looking forward to lively and informative presentations throughout 2020. If you have ideas and thoughts about our CAPS Perspective series, we'd love to hear them. You can like our Facebook page and comment to us there. You can watch for an upcoming Twitter feed where you can DM us, and my DMs are open on Twitter as well, my personal DMs for Lisa Maurice. And you can send us suggestions for quality and safety resources to post on our resource page at www.patientsafety.org. This is the information to contact us. If you go to patientsafety.org, there is a contact button, and you can send a message to us that way, or feel free to email me directly at lisa.maurice@gmail.com. That concludes our webinar for today. I want to thank our presenters, especially Erica Steed, who really has had quite a journey in patient advocacy, and it's a little bit different than your MBA in information systems, isn't it, Erica? And
Absolutely.
thanking Dr. Wyatt for taking the time out of your incredibly busy schedule to put this together and share with us. It will be shared much more widely, I am sure, over the next several weeks, and I hope everybody has a good day and warm company. Thank you so much. Goodbye, everybody.
Thank you.
You can help prevent influenza by getting your flu vaccination this fall.
Yes, get your flu vax, definitely. Thank you so much, Ron and Erica, and we will be back in touch.